you can always do individual decision making, and you can use other TKIs, Midostaurin, Gilteritinib, for example, because they are available, they are approved in AML and other indications. Gilteritinib for refractory AML, Midostaurin for induction therapy. But if you look at the actual data, then they are not supporting a clear maintenance strategy at this point. For example, in the Midostaurin trials that used Midostaurin for actual maintenance treatment after allogeneic stem cell transplantation was published by Mazinas recently in bone marrow transplantation, I think. That was a randomized trial with a comparator arm was best available therapy. And they clearly showed in the 60 patients that they included there was no difference in relapse-free survival. And we have the big study, the Retify trial for first-line treatment, where also patients could be transplanted within this trial, but after transplant they could not receive maintenance treatment. But those patients that only received chemotherapy were eligible for a maintenance phase for 1 year with Midostaurin. And the subgroup analysis of this study suggests that the drug may not be as potent in the maintenance phase as in the combination therapy phase up front. So that's why in the US it's, for example, not approved as a maintenance drug, the Midostaurin. In Europe it is approved. But the data are potentially not, or suggest that the drug is not very, very potent in this maintenance phase. And and for the Gilteritinib, we have the data for the relapse refractory patients. And in this study that was published 2 years ago in the New England Journal, by Alexander Pearl, and they showed that there's a clear benefit for the patients that received Gilteritinib compared to chemotherapy, and some of them also underwent then transplantation in remission. But the group of patients that then was successfully transplanted and then received Gilteritinib subsequently is very small, and does not really allow to draw conclusions as of the potential of Gilteritinib as a maintenance drug. And there we have the Morpho trial ongoing, which is currently, I'm not sure if they're still recruiting or if they are in the post-recruitment phase observing their patients. I think the data will be available sometimes 2025. And this is a clear-cut maintenance study after transplant, randomized, placebo control, and with first-class evidence that we can expect there from this trial. And of course, there's another inhibitor, which is Quizartinib. There was a similar study as the Pearl trial with Gilteritinib. And they also included refractory relapsed AML patients with FLT3 ITD mutations, and also some of these patients that responded that were in the Quizartinib arm were transplanted, but the same as I just said for the Pearl trial holds true for the Quizartinib trial from Cortis. There are a very low number of patients that can be evaluated, and I think that does not allow to really conclude about the efficacy of Quizartinib as a maintenance drug. And it is also seen there that the patients have real long-standing cytopenias, so that's another issue after transplant. So you really have to do a randomized trial when you want to draw conclusions. And so we don't have data for this. Yeah.